We are ready to invite our next speaker, Julia Applegate. She directs Equitas Health Institute, where she leads the LGBTQ plus health education research and community engagement efforts to improve the health and wellness of LGBTQ plus communities across Ohio and beyond. Julia's experience in curriculum design, education, and public health programming, policy development. She has worked in public health programs focused on women's health, HIV/AIDS, and LGBTQ plus health. With over 20 years of academic teaching experience, Ms. Applegate is a skilled trainer and experienced presenter who has designed curricula, conducted train-the-trainer programs, and presented at local, state, national, and international conferences on public health, HIV/AIDS, gender, and sexual orientation topics. So please welcome Julia Applegate.
Thank you so much. I am so happy to be here. I am screen sharing now, so I hope everyone can see the presentation. I am Julia Applegate. I use she pronouns. I'm based in Columbus, Ohio, at an organization that is a federally qualified health center that serves people living with HIV, the LGBTQ plus community, and a whole range of medically underserved populations. So at my organization, we have an institute which I direct, and what we do is a lot of health education on topics that affect the communities we serve. So I'm here to talk to you today about cancer disparities in the LGBTQ plus community, and I'm happy to take questions either, I suppose, along the way or after the presentation, whatever works out. So I'll make sure that I've open up my chat so that I can see the chat while I'm talking with you. So the learning objectives for the talk today are to describe cancer disparities in the LGBTQ plus community, explain the root causes of cancer disparities in the LGBTQ plus community, and identify tips to providing culturally humble care to the LGBTQ plus community. So these, of course, are for CE purposes. We have to have learning objectives. So before I start talking about our disparities and our health and how to improve them, it's important to take a little bit of time talking about what do we mean by the LGBTQ plus community. I am 51, and so there was a point in time where, just hearing the letters LGBTQ plus, the letters were arranged differently. They're not things that you saw on the news or heard on the radio, unless it was disparagingly. And now, especially in the month of June, you've got people talking about LGBTQ plus frequently, and they use the letters and they understand what that means. So things have changed a lot in our population, but I want to just spend a few minutes talking about some basic definitions. So the L, the G, and the B, these are sexual orientation terms. They stand for lesbian, gay, and bisexual. So a lesbian is a woman who's attracted both emotionally and or physically to someone of the same sex. A gay man is someone who is attracted to someone of the same sex, and a bisexual person is someone who is attracted both physically and or emotionally to someone of the same sex and someone of the opposite sex. Bisexual is an umbrella term. There are some other terms that fall kind of within bisexuality. Bisexuality doesn't mean that you are simultaneously necessarily attracted to same sex, opposite sex. It doesn't mean that you can't make up your mind. It just means you recognize in yourself the capacity to feel that attraction to both people of the same sex and people of the opposite sex. But these terms are all about sexual orientation. So that's about love and attraction, be that emotional, sexual, or both. Some people feel that love and attraction in the realm of the sexual and the emotional, it's the same. Other people feel emotionally attracted to one sex and physically attracted to another. So it's important to recognize that the love and attraction have two realms, emotional and physical. But those are all sexual orientation terms. The T is a term to denote the transgender experience. This is a gender identity term. So gender identity is in our brains. It's all up here in our heads. How do we understand ourselves in terms of our gender? And so that is different from our sex assigned at birth. Our sex assigned at birth is something that is designated for us, typically, with the advent of ultrasound technology, we can now assign sex before a fetus is even fully developed. So it's a simple visual determination based on looking at genitalia, either while in utero or upon birth. But sex is assigned based on that visual determination. It is a function of genitalia. And there are chromosomes that go behind that, but most people don't know what their chromosomes are. There's an assumption that your chromosomes line up with your genitalia. Gender identity doesn't have anything to do with sex assigned at birth. We culturally expect that if a person is born with a penis, they will understand themselves to be male, and their gender identity will be as a man. But for the trans community, there's not a congruence between sex assigned at birth and how trans folks identify themselves in terms of their gender identity. So for the trans community, that umbrella term encompasses many other communities as well, the non-binary community, gender non-conforming people, gender queer individuals. Essentially what you know for someone who identifies under the trans umbrella is that their sex assigned at birth does not align with their own sense of gender identity, with what the socially expected gender identity would be. So gender identity is up here in our heads and in our brains. Gender expression is external to our bodies. It's all the ways we tell the world how we understand ourselves in terms of our gender. So how do we express our gender? We do that with our voice. We do that with our hand. How we, do we talk with our hands? How do we hold ourselves? What clothing do we wear? What kind of haircut do we have? What colors are we drawn to? All of these things have been gendered. And so gender expression is kind of the ways that we signal to the world how we understand our gender. You would probably think of terms like femininity, masculinity, androgyny. These are ways that people express their own understanding of their gender. So I kind of covered those already. The L, the G, and the LGB are sexual orientation terms. The T is for transgender community. That's a gender identity term. The Q is a term that can mean a couple of different things. In our iteration of this acronym, we use one Q to denote both queer and questioning. So queer is a term that has a very pejorative history to it, but is a term that's been reclaimed by the LGBTQ plus community. Not all members of the community, but if you hear people talking about themselves as queer, we're talking about the queer community. Often what they mean is people who are sexual and or gender minorities. So again, it's a term that was very negative historically, but has been reclaimed by many people in the community. For folks who are 40 or 50 plus, queer has a really political connotation to it. For younger folks, queer in many ways is just a stand-in for lesbian, gay, bisexual, or trans, some combination of those terms. People are simply telling you that they identify outside of a traditional normative understanding of sexual orientation or gender identity. Questioning gets at the idea that all of these terms, all of these identities are things that in this population are questioned. It takes time to, because we live in these heteronormative and cisnormative cultures, it takes time for people to come to a clear understanding sometimes about their sexual orientation or gender identity. And while they're on that journey, a terminology that we use to describe that experience is questioning. And so we want to make sure that folks who are questioning their sexual orientation or gender identity feel seen in this population. And then the plus is a stand-in. I really think it's a lazy stand-in, but it is certainly our community has many letters to represent our very diverse identities. And so the plus is an easy way to try to capture everything else that falls under a sexual and gender minority. And that can be things like non-binary individuals, genderqueer people, the intersex population, omnisexual, pansexual, demisexual. So there are language is used to try to capture the very diverse experiences around sexual orientation and gender identity. So that's kind of our basics. We like the rainbow, so you'll see lots of rainbows in presentations that we do about this population. So when we think about cancer disparities, there are many different cancers that affect our population disproportionately. So when we talk about a disproportionate impact, if I tell you that, our most recent data, about 5.2% of the general population identifies as a sexual or gender minority. It's going to be stratified based on age, based on based on whether someone's male or female or non-binary. It's going to be different within communities of color, but just the if you take it across all of those differences, 5.2% of the population roughly identifies as LGBTQ plus. We shouldn't have more than 5.2% of the cancer burden, but we do have higher rates of cancer. So in our men who have sex with other men community, there's a much higher experience of anal cancer. For those men who have sex with other men who are HIV positive, they experience anal cancer at rates 9 times higher than people who are HIV negative and who are men having sex with other men. We don't just call this gay men because we know, again, that sexual behavior and sexual identity are not always the same, right? So we have some people who are engaging in men who are engaging sex with other men who do not identify as gay. But for folks who are HIV positive and who are men having sex with other men, there are much higher rates of anal cancer. That's why conducting an anal pap screening in this population is so important, which goes back to our earlier conversation of why it's so important to give people the opportunity to identify to their healthcare providers whether they are gay or lesbian or transgender or bisexual, because those are important health indicators. We see higher rates of breast cancer in lesbian and bisexual women, also in transgender men and women. There are multiple reasons this happens, but a lot of that has to do with apprehension for seeking preventive screenings, later stage diagnosis. If you're not getting your preventive screenings, then it's more common that when your cancer is detected, you're further along, you're more likely to have poor health outcomes when the cancer is detected. There are some other factors for lesbian and bisexual women. If these women are not pregnant or taking birth control pills, there's some protective factors that come along there with breast cancer, and those things aren't present. I'm a lesbian. I've never taken a birth control pill in my life. I have an IUD now, but that has nothing to do with my prevention of pregnancy. It had everything to do with being perimenopausal and bleeding like crazy. And, an IUD was a way to stop that bleeding as I was moving to menopause. But regardless, if you're never ingesting these medications that help with prevention of pregnancy, then and have a corresponding protective factor for breast cancer, then you're not getting that benefit. Transgender men and women, the data there is sparse, but we do know that this population needs mammograms and needs chest screenings and is less likely to get them because they have a harder time identifying providers who understand their unique needs. We see higher rates of cervical cancer in lesbian and bisexual women. Some of this has to do with, again, delayed screenings, misunderstanding of cervical cancer risk. If lesbians and bisexual women are not aware of having HPV, which they may have, and they smoke, and we are more likely to smoke as a community, in part because we have more stress. We experience minority stress, and tobacco products help relieve that stress. It's not a healthy way to do it, but it is a reality for many folks. that relationship between smoking and HPV or not getting those preventive screenings results in higher rates of cervical cancer. What else? Some other cancers. We have higher risks for endometrial cancer in lesbian women. This is tied to nulliparity and a trend towards obesity and lower use of birth control. So again, carrying a pregnancy, giving birth, breastfeeding, all of those things can provide these protective factors, and lesbian women are less likely historically to do that. So you see higher rates of endometrial cancer. The trend towards obesity. The lesbian community experiences obesity at higher rates than their heterosexual counterparts. There are lots of factors for that. Some of the things that we talk about and think about can be social isolation, experiences of minority stress, and those corresponding kind of behaviors that will result in obesity. We see higher rates of lung cancer in men who have sex with other men who are HIV positive. We see higher rates of lung cancer in lesbian women, transgender men, and transgender women. That, again, we attribute to elevated smoking rates in these populations. And so there is a national LGBT cancer network, and this is one of their images. Tobacco is a queer issue and cancer is a queer issue. So we need to think about cancer disparities in doing this cancer education work, cancer equity work through an LGBTQ lens, if we want to really kind of reduce the disparities in this population. Okay, so what are the root causes of these disparities? I started to cover this a little bit. Healthcare utilization is adversely affected by marginalization. And so this is true whether you think about immigration status, racial identity, ethnic identity, age, sexual orientation or gender identity status, socioeconomic status. If a community experiences marginalization, then their healthcare utilization suffers. So 30% of LGBTQ plus adults don't seek healthcare services or they lack a healthcare primary provider, as opposed to 10% of the heterosexual adult population. This is why an organization like ours, and there are FQHCs all around the country that are specialized in serving the LGBTQ plus community. There are not as many of them as are needed, but they're there because of this data, right? Because we know that LGBTQ plus adults are less likely to have a primary care provider, and an FQHC community healthcare setting is a way to get that primary care and mental health care, dental care all under one roof. So our population has a higher fear of disclosure of their identity status, and the corresponding that stigmatization, fears of that stigmatization that can come along with disclosure of sexual and gender minority status. There are fears and concerns about confidentiality. If you think about this nation, the United States, if this is where you're situated, the fear of disclosure can run from being fearful of your life, like could I be murdered if I disclosed my sexual orientation or gender minority status? So things as extreme as that, all the way across a spectrum to being concerned about being verbally harassed or being harassed in a social media kind of environment. So disclosure and stigmatization are still really big issues in this population, even though sexual orientation and gender identity status is protected health information. A lot of people, both healthcare providers and LGBTQ plus individuals, do not know this. We have a lack of culturally competent providers. So, knowing that there are providers who are like us to take care of us, that's the absence of those providers is something that is anxiety generating, and it works to keep people from seeking medical care. And I suddenly just had this very real fear myself that this presentation only goes for 30 minutes. Can someone just tell me, is this 30 minutes or do I have an hour?
You have another 25 minutes. We have until 2:15 before Q&A starts, Julia.
Okay, good. That's what I thought. I just wanted to make sure. There are certainly still negative attitudes on the part of providers that can value judgments, ethical or moral judgments of patients' sexual orientation and gender identity. These are things that LGBTQ plus folks are worried about experiencing negative attitudes on the part of their providers. And sometimes it's more than just the provider. It can also be, what is the actual environment going to look like where I seek medical care? How is the person who's taking my appointment on the phone going to treat me? So these kinds of things are at the root of our health disparities. There's limited research on sexual and gender minorities. And there's also a failure to collect sexual orientation and gender identity data. And so when you have registries like the SEER, those registries are not collecting sexual orientation and gender minority data, then we become an invisibilized community. And so these are some things that we need to work on changing that will help undo some of the disparities that this community experiences. So when LGBTQ folks are trying to access medical care, and the T is not denoted here because there are commonalities among lesbian, gay, bisexual, and queer folks that may be different than the experience for trans folks. So when we're seeking medical care, it's not uncommon that we may be refused care outright altogether. That is not an uncommon experience. It happens more than people, I think, would like to acknowledge. We may experience a lack of affirmation for our sexual orientation or our gender identity. We may experience harsh or abusive language by our medical providers. I went to see a gynecologist when I was, well, actually, she was not a gynecologist. She was I actually don't know what her title was, a medical doctor that was doing assisted reproductive technology. So I went to see a physician who was there to take care of my fertility challenge, which my fertility challenge wasn't really much more than the fact that my partner is female and doesn't have sperm. But I nevertheless was seeking assistance becoming pregnant. I went to see the doctor. I was there for a vaginal ultrasound to just kind of get a sense of the health of my ovaries and uterus. And I saw the wand sitting there next to the table that I was lying on while I was in stirrups. And I was concerned because the wand had a condom on it. It was fairly long. Those vaginal ultrasound wands are, they're fairly long. And I asked my provider when she came in the room how far the wand would be inserted, because I had no idea the entire wand was covered with a condom. And as a lesbian who had never had sex with a man who had a penis, I was concerned because that penetration, not knowing how far that was going to go inside my body was alarming to me. And my provider said to me, well, I can do a throat culture with it if you'd like me to. And so when we talk about harsh or abusive language, that's the experience I had that was very harsh and abusive. I was in a very vulnerable situation when that happened, and it was appalling. We also experience assaults and unwanted touching. So these are things that we have to be worried about when we seek medical care. For trans individuals, some similar situations, some similar concerns, outright refusal of care. I have a trans man friend who went to an urgent care bleeding. He was bleeding from his vagina. He still had a vagina. He still had a uterus. And he was told by the care provider, you can't be bleeding down there. I don't know what is going on with you. Get out of my clinic. And so an outright refusal of care. Misgendering or use of wrong name. So oftentimes with the trans community, you'll have an individual whose legal name may not be the same as the name that they are using in everyday life. And so maybe their insurance card won't match with their name that they sign in as. So they get dead named, or they get misgendered. They get called a he when they actually use she pronouns. Use of harsh and abusive language, again, assaults and unwanted touching. So when you're wondering, if you are, why we have these poor health outcomes, it's these kinds of experience with medical providers that produce a climate where we are concerned about seeking medical care because we don't know how we're going to be treated. So sometimes it doesn't have anything to do with the medical care that we need. It's more the fear of how we'll be treated. And then when those things happen, because they do, it affirms it's a confirmation bias situation. It's exactly what we thought would happen. And then we're like, not going to the doctor. So these expectations of prejudice and bias, I already started talking about, they can produce avoidant behaviors when we think about getting preventive medical care, including like lung cancer screenings, mammography screenings, pap smears. You know, if we're afraid of how we're going to be treated at the doctor because of our sexual orientation or gender identity, then that acts as a barrier to us seeking care, and then results in poor health outcomes. So what can we do to create more welcoming and inclusive environments for LGBTQ plus patients seeking cancer care? This is the good news. There is a lot that can be done here to help support your patients who are LGBTQ plus. So one of the biggest things that is important for serving us is to avoid assumptions. And this may seem like an obvious thing, but the number of assumptions that circulate in medical environments and really in everyday life that are based on heteronormativity. So the assumption that that everybody is heterosexual, or assumptions that everybody is cisgender. And if you're not familiar with that term, cisgender means cis means on the same side of. That means that your sex assigned at birth it aligns with your own sense of your gender identity. So if you're sitting somewhere right now with a vagina and you identify as female and as a woman, then you're cisgender. So, and consequently, if you are assigned male at birth, you have a penis and you identify as a man, then you are cisgender. Okay, that's an oversimplification of that term, but breaking the habit of guessing or assuming a person's sexual orientation or gender identity based on their outward appearance or visible cues is one of the most important inclusivity practices you can have when working with this population. So do not make the mistake that my provider has made before, where I was with my partner actually, who had melanoma when she was pregnant with our daughter, and she was getting ready to have surgery. Well, she was diagnosed when she was pregnant, but had to have surgery very soon after giving birth. So I was in the surgical environment with her, holding our daughter, who was 2 weeks old, and the nurse that was taking care of my wife looked at my wife and looked at me, and then looked back at my wife and said, "Oh, is this your mother you brought with you to your appointment?" In this case, this nurse wasn't making an assumption of sexual orientation. She was making an assumption of relationship status between myself and my wife. And so, you know, I'm only 5 years older than my wife. I do have gray hair, but there were so many things wrong there. Like, it invalidated our relationship status between my wife and myself. It invalidated the relationship between myself and my daughter. And it was just all kinds of wrong. So avoiding making assumptions based on visible cues that you see before you of sexual orientation or gender identity is a really important thing to do. Ask open-ended questions. I already started skipping ahead. I have a habit of doing this. How can we avoid making assumptions? So instead of saying things like, he is waiting for a Zoom call to start, if you say he, you're making an assumption that the person waiting for that call to start is male identified or uses a male pronoun. Instead, you can say a pronoun that is gender neutral. You can say they. If you don't know the pronoun of the person that you're waiting on, use the gender, the singular they to denote that person's identity. Do you have a wife or a husband? That presumes the sexual orientation or gender identity of the relationship of the person that you're taking care of. You could ask instead, are you in a relationship? That also assumes a monogamous relationship. What if you're seeing a patient who's polyamorous, who has multiple relationships? So, ask that open-ended question. Are you in a relationship? That allows the person to tell you yes or no. So you're not assuming relationship status. It allows them to tell you what kind of relationship they're in. Yes, I'm in a married relationship with my wife. I'm in a same-sex relationship. Or yes, I have multiple relationships. I have multiple sex partners. Let me tell you, let me share that information with you so that you can ask me appropriate questions. What are your mother and father's names? That assumes that a person has a mother and father. That assumes that they are heterosexual. Instead, you might ask, what are the names of the people who raised you? That allows people to be more open with you about what the relationship status is for them with the person or people who are taking care of them. Hey, maybe it's my grandma who's raising me. Maybe I'm living with my aunt or uncle. Maybe it's a neighbor who adopted me. So open-ended questions that don't make assumptions. Do you have brothers or sisters? Instead, do you have siblings, right? Because some people are non-binary. What's the terminology for if I have someone who, you might think of as a sister, but they're non-binary, what's the terminology we use there? Some people have used the term nibbling as a neutral way to identify a sibling relationship. Is this your sister, daughter, mother, brother? Who did you bring with you today? Again, open-ended questions allows people to identify with you the truth of their experience. So we talk a lot about in serving this LGBTQ plus community, and really this is true for any minoritized community, structural competency best practices. So when we say structural competency, we mean what is the virtual or physical environment where you're engaging with a patient, okay? And what is the impact of that environment on the patient? So things like if you're in a medical situation and medical environment in person, are there all gender or gender neutral restrooms available? If you want to be inclusive to the LGBTQ plus community, we need spaces to go to the restroom that are safe, right? So we need either all gender or gender neutral spaces, or we need to know that if they are, if the restrooms do follow binary gender categories, that is safe for a trans person, a trans woman, let's say, to use the women's restroom, that she's not going to face stigma, discrimination, or violence in using a restroom that aligns with her gender identity. Do you display visible symbols like the rainbow flag or the trans pride flag? This rainbow flag here on this slide is the inclusive pride flag. It's called the Progress Pride flag, and it's even evolving. So in 2017, this flag came into existence. It incorporates the trans pride flag, which are the white, pink, and blue colors, with a black and brown stripe to denote diversity within the LGBTQ community, because many people of color have felt like that rainbow, the red, orange, yellow, green, blue, and purple, was really a symbol of the white gay community, gay and lesbian queer community. And so adding in these other colors, if you are actually inclusive and intersectional in the LGBTQ care that you provide, then you want to use this pride flag, not the just the red, orange, yellow, green, and blue flag. So where do you display that flag? Does it hang outside your building? Does it exist on your webpage? Do your staff perhaps wear rainbow pride flags on their lanyards or on their name tag? These are ways to visibly indicate inclusivity for our community. Think about your language on forms. These can be electronic forms or paper forms. Is it LGBTQ plus inclusive? Do you ask relationship status? Do you ask about sexual orientation and gender identity? Do you allow people multiple choices when they're designating their assigned sex at birth or their gender identity? Can they select more than one option, right? So like in my case, I would want to click off assigned female at birth. For my sex, I would want to click off for my sexual orientation, lesbian and queer, because I identify as both. I would want to click off for my gender identity, female, gender queer, and gender nonconforming, because those are all parts of my identity. So give people choices. If you have a policy around pronouns and gender inclusive language, make that visible. Make sure that your policies are noted in a physical waiting room, or they can be found on a website. You want to make sure that your organizational culture is reflected in the policies that exist in an environment, and make sure that your patients know about those things as well. So when we talk about structural competency, these are some of the things that we're getting at. So it's increasingly important to think about both physical and virtual spaces. And so one of the things that we can all do is we can add our pronouns to our signature in our Zoom setting, like I have there. And sometimes you have to go in and redo that, but you won't have any question about what pronouns I use if you see it right there. Okay, put these in your email signature lines. There's so many ways you can do it. It's so important to get this right in the queer community. For many people, not just queer people, a name it's one of the most important ways we identify ourselves. For me, my name, I'm named after two grandmothers, and I consequently want to pay respect to both of them. And while I'm not that fond of my middle name, I always want my middle initial in anything I do professionally, because that is my homage to my grandmother, Margaret, who I was named after. My other grandmother is Julia. That's really important to me. For trans individuals, their name is a critical part of their identity. They name themselves, right? It's not a parent who names trans individuals. When they choose their name, it is so much thought and care goes into that. And it's so important to make sure that you get that name correct. To dead name or misname a trans and non-binary person is invalidating of their identity, and it can range from just feeling mildly aggravating to being a very traumatic experience for folks. So if we know that a person is trans, we should do everything you can to avoid addressing them by their birth name. Avoid that verbally and in print. There are times when you can't avoid that in print because of things like a legal name for insurance purposes, but you can go to extra lengths to write in your electronic medical records, write a note. Hey, Jeremy goes by Shelley, and let's make note here that Jeremy's that name is only for use for legal purposes when we do billing. So things like that. Pronouns are really important as well. A pronoun is another extension of identity. For individuals who are misgendered, it can be invalidating and aggravating and traumatic. I've shared with you, I identify as genderqueer. I do not identify as transgender, but I am misgendered frequently. I have been ever since I won the war with my mother and got to cut off my pigtails. So being a female who has short hair and dressing in a more androgynous or masculine leaning way, going to a public restroom is always a space where I'm on guard for being misgendered. So in my case, when I'm called he, I don't feel comfortable. If I were trans and I used male pronouns, then it would be uncomfortable for me to be called she. So recognize that you may not mean harm when you make a mistake about someone's pronouns, but the person you're interacting with, they may have been misgendered earlier that day, maybe multiple times. Maybe it's just so triggering to be misgendered that it can cause a person to decide not to seek medical care. So it's just something to think about when you serve this population, how important it is to get names and pronouns correct. So some best practices for pronoun usage. It's important for you to share your pronouns and your name. So when you introduce yourself, hey, my name's Julia, I use she, her pronouns. I could then say, what pronouns do you use? Or maybe I don't want to ask that directly, but I just introduce myself with my pronouns. If you're working with a trans or non-binary patient, then they immediately know, because you've done that, that you understand how important pronouns are, that you are implicitly asking them what pronouns they use. So it's an important signal of inclusivity. If you make a mistake, the best thing you can possibly do is apologize and move on quickly. Do not do the worst thing that you can do, which is over apologize. Don't say, hey, you know, I just went to a class and learned about this. I can't believe I got it wrong. Or my cousin is trans. How could I misgender you or dead name you? I'm so sorry. All you're doing is drawing attention to the fact that you've just done something harmful to someone. So quickly apologize, move on, go talk about your mistake with your therapist or your best friend, and let them help you feel, you know, get over your feelings of guilt. Don't ask the trans person that you've just done this to do that for you. Practice getting people's pronouns right, even when they're not around. So don't be lazy. This is something people do. They'll say, oh, you know, oh, Jeremy transitioned and I've been working with Jeremy for 32 years. And how am I supposed to remember to call her or him? I don't even know what they are. Sally now. It's so complicated. It drives me nuts. Don't do that. Don't do that. Work harder. Think about it in your head. If you hear your colleagues doing that in the break room, or when, you know, when Sally's not around, correct them. It's really important to do that, go to that length. So even when the person is not hearing someone use dead names or the wrong pronoun, then correct them. If you don't know what pronouns a person uses, you can default to the singular they. I mean, it's something that we've used for years. I know there are many people who get stuck on grammar and they is plural. The singular they was the word of the year in 2015. The journalistic guidelines, I think it's the APA guidelines, now you have the authority to use they in the singular. It's in the dictionary that way. So be thoughtful about that and don't get hung up on outdated grammar. So here are some examples. When greeting others, you can avoid things like ladies, gentlemen, sir, girls, guys, ma'am. Consider instead using things like, hey, thanks, friends. Have a great night. Good morning, folks. Hey, everyone. And for you, can I get you all something? These are shifts to gender inclusive language that respects and acknowledges the gender of people all around you. It avoids the opportunity of making assumptions, and it's the most affirming thing that you can possibly do. Okay, so special considerations when serving trans individuals. Avoid assumptions about gender affirming treatments and about what parts your trans patients may or may not have. So not all trans individuals make surgical changes to their body. Not all trans people take hormones. So you want to ask questions that are open-ended, that allow people to tell you what their experience is. Ask about parts if you're going to do that, if that's necessary, with sensitivity. You can start that by allowing people to do a anatomical catalog in their patient information. So you're asking people what parts do you have? And this is relevant not just for LGBTQ folks. My mother had an emergency hysterectomy because she had cervical cancer when she was like 34. She didn't have a uterus. So her doctor really should have wanted to know in a primary care environment, do you or don't you have a uterus, right? So like an inventory of anatomy is the best way that you can go. So ensuring that your patient feels affirmed in your clinical environment will go a long way. And the image you see here is a photo shoot that we did in Columbus, Ohio with a trans woman and a trans man when we created our documents about risk factors for mammography or for breast and chest cancer in this population. And so pictured there is a trans woman who's over 40 and has been on hormones for more than 5 years and now has breasts and needs that annual exam, and a trans man who has not had a top surgery. He still has breasts and he also needs an annual mammogram. Okay, so let's bring it all together. How do we create environments of respect and trust? Refer to people by their chosen name and correct pronouns. You have to ask them about their pronouns or give them a space to reveal that to you, so you can do that. Protect confidentiality when it comes to sexual orientation and gender identity. Make sure your patients know that you do that. Educate your staff and colleagues regarding LGBTQ plus issues. Education goes a long way, and do it not just once, but do it regularly, because as we know, people change, communities change, language changes. Respect patient wishes regarding potentially sensitive physical exams and tests. You know, it can be difficult for the patient just to get into the room. And so some of the fears can be allayed by letting them know that their information will be protected. Be familiar with commonly used terms and the diversity of identities within the LGBTQ plus community. So do not make the mistake that all LGBTQ plus individuals are white or have money. I mean, there was a period in time when they talked about the gay dollar. Well, I'll tell you who had that money. It was not lesbians. It was white gay men who were educated that had, they called it the pink dollar. They're the ones that had all the financial resources. Let me tell you that I knew a lot of lesbians who were white, black, brown, who were all kinds of socioeconomically disadvantaged. Be non-judgmental, open, and professional. Provide client-centered care. Meet patients where they are. Give them the opportunity to tell you who they are and where they are in their relationship to health and wellness. Go beyond allyship. Be an accomplice. Okay, an ally is, hey, it's a good thing to say you're an ally, but it's not a very active oriented identity. An accomplice is someone who's like, hey, I'm not just gonna fly the rainbow flag during Pride Month. I'm gonna make sure that it's on my lanyard year round. If I see someone being misgendered, I'm gonna go over there and intervene. If you see something, say something. That's what being an accomplice is. It's being active in your service and support of minoritized communities. So just some quick things about the campaign that we have. We are funded by our state health department through breast and cervical cancer prevention programs that start with the CDC. We have a breast and chest health education campaign. We train medical providers, mostly mammography and nurses, providers at certified oncology centers around the state of Ohio. We have a campaign that also trains or teaches our LGBTQ community members about their risk factors. So we have this thing we call the Check 'em Challenge. That's something we do annually with LGBTQ individuals, where we educate them about their risk factors. We encourage them to do self-exams. We encourage them to get mammograms. We connect them with providers we have trained so that they know that there are providers who are culturally humble, and we make sure that we do that regular training with those providers. And then when they take our challenge, we give them all kinds of cool swag. Here are some examples of the swag that we share. You'll notice that, oh, I hope I haven't gone too far. I need to get into questions in here in just a minute. That our materials that we give people are rainbow, and you know, this is on the yellow shirt. That's a picture of a trans man who's had a top surgery. He still needs to check his chest. On the hat there, that's that image you can't tell in this version of it, but it's a person of color who's queer kind of identified. Okay, so you can reach me here by phone, by email. I'll pop into the chat a link to our webpage where you can see and download some of our resources. Happy to answer any questions.
Thank you so much, Julia, for that crucial conversation on how we can create more safe, welcoming, and inclusive environments for our LGBTQI+ community. So I'm going to start off with a question. You know, we talked about creating these safe environments because a lot of people have a fear of sharing their sexual orientation and gender identity. And so that starts with the environments that we create in these healthcare settings. So oftentimes when we're working with our patients, we want to be able to refer them to an organization or an individual that we know is competent, culturally competent to work with this community. And sometimes that involves a direct handoff, right? You know somebody, so you call them up and you say, I know this person, you're safe in this environment. Do you know if there are any resources for us to find more organizations or individuals that are trained to serve the LGBTQI plus community so that, we know it's a safe, welcoming, and inclusive environment?
Sure. There are directories that you can get. I can't speak to ones that are specific to California, but I can tell you that there is a group called OutCare, and I'll put that in the chat. If you just Google OutCare, they have assembled culturally humble providers. It's all self-report, but they've assembled providers in many different kinds of disciplines from all over the country. And so they have a searchable guide online that you can look at. The Gay and Lesbian Medical Association has listings. And again, this is all self-report. So if you look in the Gay and Lesbian, the GLAMA, it's GLMA directory for Los Angeles, that doesn't mean that if you see 3 people, there are only 3 people there. Only the people who go to the effort to report themselves as inclusive to the GLMA are going to end up in that directory. We in Ohio, we put together a directory of LGBTQ providers for our state. And what else? I know the American Psychological Association has a list of psychologists who are friendly. So, unfortunately, you have to do some looking around to find these resources. They can be found. They're not as easy to find, though, as they should be.
Very true. And I think also that HRC has their HEI index.
Yes.
Right? That you can look up, and every year organizations, and I know we're City of Hope has applied and received that scoring to where you have to show that you have all of these services in place and training to be able to serve the LGBT community. So I think, yes, the Healthcare Equality Index. So you can also share that. So our next question, Julia, is, are you familiar with rainbowwelcome.org?
I am not familiar with rainbowwelcome.org.
So whoever asked that question, if they would like to give us more information, we'd welcome that.
Yeah, I would love to hear about them.
Our next question, Julia, is Asian Americans are not represented in the transgender pride and race and LGBTQ flag you shared. Any thoughts?
Any thoughts? I think that's an absolutely good point. I think that in much the same way that, when we're talking about diversity, people are always collapsing, right? Like we've collapsed in I, A, P, D, O into a plus. I think the answer would be to the person who designed this flag, well, they're represented in the brown and the black. And that's not inclusive. And so I noticed when I was looking recently that this version of the flag that I mentioned has been had some other symbols added to it. So I think that you'll continue to see this flag evolve to be more inclusive. And yeah, I guess I'll say that, it's lazy.
All right, thank you, Julia. Our next question is asking, what are the primary gaps evident in cancer care for the LGBTQ plus community?
Primary gaps, oh gosh. I'm sure that, sorry, my slides are moving. I guess it doesn't matter anymore. I think access is an issue, right? Like, so LGBTQ people live everywhere, all right? There's this kind of outdated belief that migration happens from small towns to urban centers or to the coasts, and that's where all the LGBTQ people are. That has never been true, and it's certainly less true now than it's ever been. So, you may have urban centers where there are rainbow flags waving outside of clinics, and that's great. But what about the people who live in rural environments? Or what about the people who, like someone mentioned, in Los Angeles, it's so gigantic. Well, so what if you have one clinic in one part of town, if there's no bus transportation for me to get there, or it takes an hour and a half to get to that area, and those are in the white queer areas, then that's not helping the Black people or BIPOC people who are queer. So I think availability of resources, the ability to access them, the training is not comprehensive for medical and social service providers when we talk about just understanding the unique needs of LGBTQ individuals. That's starting to change, but so just because you've got new medical students who are learning that now in 2021, 2022, how long is it going to be before they're taking care of LGBTQ people, right? I mean, for people in my generation, I thankfully haven't been sick. And so I was able to get by with having doctors that didn't understand me. But I'm aging. And as we all know, as you age, you need more medical care. And how many physicians am I going to be able to find that understand my identity? It's a stressor. So there's also LGBTQ folks are more likely to be uninsured or underinsured. We're also more likely to be living in poverty or be living at socially disadvantaged categories. And so all of those things together just to make our relationship to health and wellness more difficult.
Yeah, thank you, Julia. And there's a lot of work to be done. And luckily, there's a lot of us who are willing to do that work. Our next question, Julia, is a lot of Breast Cancer Awareness Month messaging revolves around pink and taking care of breast health as a woman's issue. Do you have any suggestions on making this Awareness Month more inclusive with its messaging?
100%. And that's why, you see in this picture here, there's two of my staff. The person in the middle is our representative at the state health department. With this contract we have with the state, we partnered with our local academic medical center, the James Cancer Unit. And so they brought out their mobile van to our clinic site because people know our space as a safe space for LGBTQ+. And of course, their van is pink. But you see, we're wearing green. We have on our hats that you can't see the brim, but they're rainbow. They're trans pride color, and the banner next to us is in brown tones. And so all of those things are things that need to be done. There need to be images of trans and queer people, and they're within any community, there are signifiers of queerness or transness that can be picked up on by our population. And so whether it's that tattoo on the arm or braids in the hair, that doesn't always mean people who have tattoos or braids are queer, but those are some signifiers of our identity. We need to see our race for the cure, not just pink washing the whole. I mean, in Columbus, everything is pink at that race. And, I get it, right? Like you have baseball players swinging pink bats. So, and in some respects, this has really worked, this pink washing of breast cancer. But not everybody likes pink. And it's not just queer people or trans people who don't identify with pink. There's a lot of heterosexual women who don't identify with pink. And I'm getting on a soapbox. I find it overdone. I think there needs to be much more diversity in how breast cancer awareness is done. And, let's capitalize on the ways that the pink washing has worked, but let's not stop there and rely on it to be the way that we communicate with all people who are at risk for breast and chest cancer, because if you do, then you continue to perpetuate these disparities.
Thank you so much, Julia. That's very true. And I think it also starts with making sure you're inviting the right people to the table, right? It's the whole idea of DEI. If you don't have somebody who's going to tell you, hey, we shouldn't go with pink because it's going to exclude some communities, and making sure that all the materials in all of the health education programs that are based on that co-design model, right? That user-centered design, what population are you targeted? That population should be involved in the whole process, because it might not be something you think about because you might be okay with pink. You might be okay with calling it women's cancers, but we need to make sure we're inclusive. So thank you. And
You're
I
welcome.
think we have time for one more question, Julia. And this question has been asked in a previous discussion because of isolation, sometimes from family, from old friends, et cetera, as well as some broader social isolation. Is a shortage of caregiving a greater problem in this community? If so, how is this addressed?
You know, I don't know data on this one, but I can tell you that that caregiving looks different in this community. So oftentimes, maybe because of family, you know, so let's just say, okay, someone my age, many people my age who are lesbians didn't have children, right? So we don't have offspring to take care of us as we age. Maybe our parents rejected us. So if we get cancer when we're in our 40s and our parents are still around, we don't have our parents to rely on. For many, many years, we couldn't get married. And so maybe, hey, maybe my partner of 15 years has really great health insurance, but I wasn't allowed to be married to her, so I couldn't get on her policy. So here I'm the one with cancer and I have no medical care. Someone mentioned fictive kin, and I hate that term because of the term fictive in front of it. Kinship is about not being necessarily blood related. And so we do form networks. And so it may be my closest friend or my roommate who takes me to my doctor's appointment. So I think we have to think of caregiving more broadly and know that there probably is a higher likelihood of isolation in this population, but also know that our caregivers may not be legally related to us, either through blood or through marriage, or they may, you know, you may have a community of caregivers, especially in the lesbian community. You have large networks. I'm part of an online forum, and when it's the Ohio Lesbian Festival community. When somebody in that community of 5,000 people has cancer, then the boards light up, and it's like, okay, our friend Jennifer in Newark, Ohio has cancer. All right, let's get the potlucks going. Let's get the online giving platforms up and running. Let's make sure that there are multiple people getting her to her appointment. So it may be a rotating group of people who are caregiving for someone. So those are the things that come to my mind to think about with caregiving in this community.
Thank you so much, Julia. And it was a really informative presentation. And I think if somebody can take away something from today, the least they can do today is add their pronouns to their Zoom name, like you said. And you have she, her, I have she, ella, because I speak Spanish. So I added my Spanish pronoun as well. So, I mean, it's something simple. You got to do is go to the three little dots on the upper right-hand corner when you're in a Zoom, and then just go to rename that. Or if you know, for me, I have it in my Zoom account, something that, you know, it regularly happens, but every once in a while it's not there. But yeah, if you're looking for the simplest thing that you can do today is that and add it to your email signature. So thank you so much, Julia. We really appreciate it. And now, before I let you go on a break, I know one of the last questions in our roundtable was about the mental health needs of healthcare providers. And I wanted to share with you a wonderful resource that was born out of COVID. And it's called the Emotional PPE Project, because we were all worried about the physical PPE, right, when we were running out, but nobody was thinking about the emotional. So if you, and they'll add it to the chat, it's www.emotionalppe.org. It's a service that connects healthcare providers with mental health professionals for free, so that you have someone to talk to about your anxiety, your fears, your concerns that you've been suffering through with COVID, with, you know, being overwhelmed during this pandemic. So it's a free resource. So please take advantage of that. And I think that was added into the chat